Great, so thank you. We're kind of at the end here, so I appreciate everybody inviting me to the conference today, and I appreciate presenting. So I am a licensed psychologist. I'm certified in an area called behavioral sleep medicine, and I have a practice that's exclusively focused on behavioral sleep medicine. So I'm really pleased to be here today. And with this topic, motivational interviewing, the reason I thought this would make a good topic for a presentation is that when I do my insomnia presentation, in fact, they were almost more interested, I would say, in medication and asking a lot about medications. And so I thought this would be a really good topic because motivational interviewing really looks at behavior change and how can we help people to make changes to their behavior in terms of how can we help them with motivation. And motivation for all of you is a key issue, right? Whether it's for sleep apnea, being motivated to use CPAP or the oral appliance therapy, or even Inspire. I mean, with Inspire, the person has to follow up and do the testing and get the endoscopy first, and all of that requires them to make changes to their behavior. Hypersomnia, narcolepsy, they might have to take medications, and so that would be an issue of motivation. They need to be motivated to do that. So what we want to talk today about is ways to understand patients' motivation and to be able to communicate with them in a way that facilitates increasing motivation for them. So I wanted to show you just a short video, about a minute or so, that kind of shows the challenges that we have in our field.
All you have to do to get an amazing night of sleep, the best night of sleep of your life, is simple. For the last hour you're awake, don't use your phone, okay? Now, is that something you can all try?
No.
No.
What? No.
How about just the last 20 minutes right before you go to bed?
I really don't. That's even worse.
So it seems like sleep isn't really important to you.
Sleep is the most important thing in my life. I would take any pill. I would have any surgery for a better night's sleep.
Same.
Definitely, I would do that.
Okay, how about just the last 5 minutes that you're awake?
No.
Wow.
I really don't think so, doctor.
Like maybe put your phone down, you go brush your teeth, use the toilet, go to bed.
So you expect us to sit on the toilet without our phones, like in Amish?
Yes,
That's crazy.
just the last time you use it right before you go to bed.
Okay, so what time of day do you recommend that I go on WebMD and look up what all my rashes mean?
Yeah, when should he look up his rashes?
Now,
All you have to do,
does this seem familiar? Do you experience this in your work ever? Because it certainly rings true with what I experience. So, I have to nervously laugh about that because it definitely is familiar, as it would be. So, today in the presentation, I wanted to talk a little bit about what is motivational interviewing. I wanted to briefly touch upon the history of it. I also wanted to talk about the stages of change model, which kind of goes in hand with motivational interviewing. If there's time, we can do a video example. We'll see if there is time for that. So what is motivational interviewing? I'm just going to read the description of it. It's a client-centered directive method for enhancing intrinsic motivation to change by exploring and resolving ambivalence. MI helps to examine discrepancy between current behavior and clients' self-identified goals and values. Now, a lot to unpack there. The first is it's client-centered. And this is really, part of motivational interviewing is really looking at what is the patient's motivation for things. So it may be that a patient is motivated by a certain thing with CPAP or treating their sleep apnea that we're maybe we're focusing on that they're not, crashing their car, but they're focusing on meeting requirements that they might have for their job or something like that. So people have different types of motivation, and we really want to find out what that is, because it always works better when we're following our patients, what they're motivated for, as opposed to kind of the information always that we're giving them. They might not resonate with that. The other thing is it is directive in terms of it's kind of moving forward, that in conversations with people, we want it to move forward in that they're increasing their motivation through the conversations that we have with them. We're enhancing intrinsic motivation, so again, their own motivation and finding out what that is. And ambivalence is a big part of motivational interviewing. Ambivalence, it's where you might hear your patient say one thing and then say exactly the opposite thing. So they say, I'm so exhausted, and if there was a way to feel better, that would just be great, but there's no way that I would use CPAP. And so you're kind of hearing both aspects of things at the same time. And part of motivational interviewing is how do you handle ambivalence, and how do you kind of lead them out of that, in a sense. We also are looking at the patient's goals and the discrepancy there between their own goals and the status quo of what's going on. So if they're wanting to play with their grandchildren and they tell you, yeah, I'm with my grandchildren 3 times a week and I want to be able to run after them and play and everything, but I'm so exhausted. That's kind of like a discrepancy, right, between what they're really wanting and where they are with things. So if we can kind of help them resolve that, it can take them to the next step with their motivation, really. So I did want to talk, so I wanted to show you a video. This is one of the people who actually originated motivational interviewing, William Rolnick, and he's going to talk a little bit. He gives a good description of it.
Fundamentally, motivational interviewing involves a change in role, a change in how you think about what you're doing. You're not the expert there to fix the person. You don't have to make the person change. The truth is, in fact, that you can't make a person change. You don't have to be the one to come up with all the good ideas. A person with really good ideas is sitting across from you and may have better ideas than you do. It's not like a competitive sport. It's not like wrestling where you try to defeat and pin and outsmart and outwit the person. It's more like dancing together, moving together, adjusting your movements to the other person. Overall, motivational interviewing is not a directive approach. Neither is it just a following approach. Following is listening to the person and kind of going wherever they go. Motivational interviewing is in the middle, between those two, and we describe it as guiding. If you go to another country and you hire a guide, you don't expect the guide just to follow you around. That's not what you're looking for. Neither do you expect the guide to order you when you will arrive, when you will leave, what you want to see, what you will enjoy, what you're going to do. That's not a good guide either. Good guiding involves good listening, as well as using your own expertise. A good guide will find out where you want to go, what you're interested in, what you're hoping for on this journey, and then help you get there using his or her own expertise, enjoyably, safely, efficiently, perhaps. That's the guide's job. Not solely directing, not solely following. There's some of each in it, but it's a blend of those things. This may or may not be the way you've been thinking about your own work, but we invite you to try it out.
Okay, so I wanted to talk a little bit about the history of motivational interviewing because I think it's pretty interesting. It was developed around the early 80s, and it was developed with addictions treatment. And it was interesting that at that time, there was a certain approach to addictions that was pretty much standard in the United States, not so much in other places. It was focused on let's take alcohol, for example. Perhaps it was looking at alcoholism as a disease and looking at it as there were various kind of personality qualities, characteristics, character really, that a person might have that would be defense mechanisms. I don't know if you remember from psychology, and Freud had the defense mechanisms. So there were things like denial, right? Not really seeing that you had a problem with alcohol, or projection. Well, of course, I'm going to be drinking a few beers after working for my boss. You know, it's that difficult. And so it was a certain view of the problem. So what was the way to address that? And how did counselors at that time address that with them? Well, the patient had to really accept their diagnosis, right? And maybe that would mean accepting a label that they were an alcoholic. So there was kind of an effort for the counselors to really sometimes argue with them, sometimes really fight with them, to get them to really understand and break through that denial, because denial was not seen as easy to break through. If the patient pushed back against that and said, no, I don't think I'm an alcoholic, what happened? Well, there was more focus on that, right? Or that was seen as an evidence of denial again. So there was more work at breaking down the denial. Argumentation and correction was used as a way of interacting, and the goals and strategies of change were really prescribed by the counselor. So often with alcohol, the goal was abstinence, right? That was pretty much it. If a patient said, I'd still like to drink at a wedding or on weekends, that was kind of seen as not really following along, and again, evidence of denial. Now, I have to tell you, all of us, probably everybody in this room, has been touched by addictions in some form or another, right? People you know, all of that. So definitely these approaches have been very helpful and have really helped countless people. However, at that time, that was really the only approach to substance abuse. Since then, and with motivational interviewing and other approaches, the field of addictions is much more open in terms of just lots of different techniques and things that they use now. So I think when motivational interviewing started, it was kind of a reaction to just the way treatment was done at that particular time. And it was a little bit of a pushback, but it was really, I think, was very nice, and that it added different approaches to this and just different ways of viewing things. So I wanted to talk about the trans-theoretical model. Now, this is also, I guess I would say, in the past, the view was people are either motivated or they're not motivated. And in addictions treatment at that time, it was viewed that if you weren't motivated, then you were kind of, in a way, what could we do with you if you were unmotivated? And maybe the person would have to go outside of the treatment program and hit rock bottom. And then they would maybe really have a sense, no, I really need to address this, and kind of come back into treatment and things like this. So this was the idea that motivation isn't black or white. It's not either it's there or it's not, but let's expand upon what that actually looks like. So if you start right here where it says not thinking, that's kind of where people start, right? Pre-contemplation. Those are your patients that come in and they say, you know, my wife says I snore, and I don't know, well, my parents snored, my grandparents snored, it's just kind of always been in the family, but she really wanted me to come in. So those are people that might not be aware at all of sleep apnea, or maybe they've heard about it, but they haven't really looked at that themselves in that light as maybe I have sleep apnea. So if you think about that, there are some things that the clinician can do based on the stage that they're in. Maybe it would be providing education. Maybe it would be helping them to look and say, oh, I never thought about it like that. I never thought it could really be like this. One personal example of that is I've always known about exercise. Exercise is wonderful. There are certain health benefits to it. What I wasn't aware of until, a while ago was that I was sitting all day in my office, and that's not so healthy. So that was something I was in pre-contemplation about, although other health behaviors I was aware of. And so it could be your patients are very much aware of certain health things, but they might not be about their sleep. So then what happens with the arrow is they go into contemplation or thinking. This is that stage when they're interacting with you and they're realizing, oh, sleep apnea is a thing here. They haven't gotten to the point where they're ready to get treated yet for their sleep apnea or whatever it is. This is where you see that ambivalence. This is where you kind of see, oh yeah, this has been a problem for me, but I don't know that I'm ready to do what you're recommending. Or maybe it's not that big of a deal, really. And what this model says is that's totally normal. It's a really normal part of things, and it's a part of change. And when people are able to resolve that ambivalence, that's a health behavior in and of itself. They might not even be using CPAP or an oral appliance yet, but they have made a step in the right direction. So what is your job in that stage? If you notice a lot of ambivalence, your job is to help them to tip the scale of that, to make it so that they're more on the side of the change that they're describing rather than the status quo. And so there are ways that you can kind of emphasize that with them so they're more likely to kind of tip the balance and go on to the next stages that you're wanting for them. There's also preparation stage. That's before they've even, they haven't gotten the CPAP yet, they haven't gotten their dental appliance made, and they're just kind of thinking about the process. A good example of this in the area of smoking cessation. If you call the Wisconsin Tobacco Quit line and you talk with them, usually what they'll do after conversation is say, well, would you like to set a quit date for stopping smoking? They don't say, wow, we had this great conversation, just throw away those cigarettes right now, because they know there needs to be that preparation time first and that people are in a better position when they've had that. And so it may be, and kind of thinking about what we do, there's a built-in preparation anyway, because it takes a little while to get that oral appliance made or to get their CPAP setup scheduled. So it might be that then that's that time to make sure they're engaged, to make sure, that they're getting to that next step or they're having that appointment to get their CPAP set up. The next stage is action, and that is actually when they're making changes in their behavior. And so they would be actually taking the steps, maybe right at the beginning of when they're using the CPAP. So what are you guys doing? You're asking them, do you have questions? How is the mask fit? You're meeting with them maybe after a week to see, with the purpose of helping them to be able to go on so that they get to maintenance. So then it's just a daily thing. They don't even think about it anymore. But as you know, it can be bumpy in the beginning, and you want them to be able to kind of maintain that motivation through into maintenance. The interesting thing about this model is that relapse is right there. And the reason why it's right there is because it's part of the process. So the idea is seeing relapse as a normal part of the process. So maybe you have somebody, I talked to somebody the other day, all of a sudden they just couldn't tolerate the mask. And so they just stopped using it for a while. Or they go on a trip to Europe or they go camping and they stop using it and then they stop for a while. So then what does the clinician do? They're kind of looking at that relapse, helping them to normalize it, right? To say, oh, you haven't failed at this. This is a normal part of the process. And remember, this is kind of a lifelong behavior, these things, right? It's not just using CPAP for a month. So we're really helping them to get through the relapse, know that it's a normal part of the process, and then helping them get back in at some point. Now, some people get right to the maintenance. Some people have to go to contemplation again. Some people have to prepare again. So it's kind of seeing where do they need to go to get back in to the model. Now, think about that very first video we saw, and you think about the audience. Do you have a sense of what stage they were in, that audience? The air conditioning just turned to not thinking. It could be they were kind of not thinking about it, but I was thinking because they were actually in a group and they were kind of saying, this is really important, sleep is really important. I was thinking that maybe they were more like voluntarily wanting to be there. Maybe if they, and I think especially the guy who said, sleep is the very most important thing, made me think that they were kind of there for a reason. So could be they weren't thinking about it, but it could be that they were actually in the thinking contemplation stage. The other thing that I thought kind of indicated that was the ambivalence that you heard there. That they were saying, oh, sleep is the most important thing, but they were also saying, but no, I'm not going to give up my phone. So that's kind of that ambivalence that often indicates they're in that contemplation stage too. So this is a wonderful tool that you can use with your patients, as you can kind of think about where they are and where you want to go with them. Now, in that video, the person who was directing the group, was he in that stage, the contemplation stage with them, or was he in a different stage altogether? Because he was talking about just giving up your phone, right? He was saying, oh, just give it. They weren't even there yet. They weren't ready for that. So here he was suggesting, just give up your phone. Can you do it for 20 minutes or maybe even just 5 minutes? But they weren't there. That's action. The clinician was in action. They were in contemplation still. So what you could do in that situation, if you find people are pushing back with what you're saying, is that you could say, oh, there are lots of different ways to get better sleep, but I'm more interested in what you were saying about how important sleep is to you. Can you tell me more about that? That is then getting them, back so everybody is kind of on the same part of the wheel there, and that they don't resist. So resistance is a big part. People can resist. If you tell them something they don't want to hear, they will resist. And what you're trying to do is roll with the resistance. If they're resisting, then you take a step back and you do something else. So I wanted to talk about some of the specific techniques that you can use in motivational interviewing. And so ambivalence, there's an example of it. Using CPAP could help me to feel better, but there's no way I'd wear the mask. In that, there are two types of communication. One is change talk. That is talking about change, right? Using CPAP could help me to feel better. You see that because that could include desire. I wish I could use CPAP. Ability, I think I could use CPAP. I need to use CPAP. CPAP would be great because it would keep me awake during the day, so they would give a reason for it. And if people are talking like that, you want to reinforce that. You want to kind of reflect that back to them. because that is what leads then to commitment and then taking steps. Sustained talk is client speech that favors the status quo. So there's no way I would wear that mask. So take that first one here. I need to lose some weight, but I hate exercising. What do we sometimes do? We sometimes emphasize the status quo. So we might say to them, exercise really isn't that bad. It's really kind of fun. You have to find the right exercise. And what do they say? They say, no, I don't like exercise. I don't think I could find something that I like. Then they're pushing back, right? So if you take the first part of that, the change talk, and you say, oh, you need to lose some weight, and then you're listening to them as they talk more about that, then you can get to a point where at some point they could maybe talk about the action of what actually to do with it. So what we're trying to do is kind of identify the statements that people are making regarding change and what they're saying that's kind of keeping them where they are with things. Most of motivational interviewing involves reflection and listening, really. And when you talk to the experts that do this, they say, oh, you got to be listening and doing reflection about like 90% of the time when you're with a patient. It's really hard to do. But basically what you're doing is you're reflecting back, and you're reflecting back the things that are going to be helpful. So if they hear from you, because you're hearing their change talk, they're going to hear that, and it's going to make an impact on them. So it sounds like you're feeling, it seems like you, that is kind of reflecting back, and they're hearing that then from you. It's actually themselves, right? It's what they're saying, but then they're hearing it from you. You can actually reflect sustained talk, and this example shows that. So the patient says, well, I do drink most days, but not that much really. And what does the practitioner say? Instead of saying, oh, that sounds like a lot, or oh, do you want to make some changes with that? They say, oh, you're a pretty light drinker. What does that do? It disarms patients so that the person, they can hear that. And so then they think, oh, that's not, well, I'm not too sure about that. And then they might go on and says, well, my spouse says I drink too much. And then the conversation goes from there. So reflecting can really help the conversation to kind of move forward. The patient says, I don't believe this sleep study. I don't think my sleep apnea is that bad. And you could say, oh, your sleep apnea hasn't caused you any problems. And surprisingly, they sometimes then say, oh, well, but yeah, I think it has caused some problems, and I really would like to address it. So you're reflecting sustained talk, and you're reflecting change talk as well. Asking questions is a part of motivational interviewing as well, and you always want to ask those open-ended questions. I mean, we do have to ask some yes or no questions, certainly, but for motivational interviewing, open-ended questions can be really good because then you're getting all the information from them. And so starting out, like, how can I be most helpful to you today? Or tell me more about, or you've had your CPAP for a month, what would be most helpful to talk about today? Why might you want to use CPAP? If you did decide to make this change, how would you do it? So it's, again, getting the answers from them is really helpful. How important is it to make this change? There's also pros and cons. This is a little weird. This might sound kind of strange. But the first question that you'll see here is, what do you like about your smoking? Now you think, oh my goodness, why would I emphasize that? Why would that be the first thing I ask? But actually, it allows them, again, to open up. It shows that you're kind of listening to them and you're willing to hear that. So that kind of reduces their defenses so that then they can kind of tell you about that. Now once they're telling you, oh, this is what I like about smoking, then you can ask, what do you not like about smoking? And they're often willing to, just part of the conversation, they're able to go to that end of things too and really elaborate on that. So partly it's what you're already doing, right? Establishing a good relationship with people so they feel comfortable in talking about these things. What would you like about turning in your CPAP when somebody says, I think if they pick it up, that's fine with me. I couldn't care less. But then asking them, well, what do you not like about turning in your CPAP? Or what might be some of the things you're not happy with that? So generating good conversation about it. Rulers are kind of fun to do. Rulers can really help you determine where a person's motivation is. So part of it is you're asking them about their confidence to do something. What is your confidence to be able to use that oral appliance? How confident are you? And you're using a rating scale. So you'd say, you know, if you had to rate between, let's say 0 and 10. 0, you're not confident at all. 10, you're very most confident in using CPAP. Where do you think you are? And it's interesting, right, to see what they would say. And you could use that with confidence, but you could also use that with importance. How important is it to use CPAP? You could use it with readiness. How ready are they to do it? And that all gives you good information. Think about two people. One is very confident, but they don't think it's important to do. The other thinks it's really important, but they're not very confident at all. You would probably react very differently, right, to those two patients. And to get a sense of that can be really helpful for increasing their motivation, too. You can also do little tricks with your ruler as well. You can say, oh, so 7, 7, you're about a 7 for confidence for using CPAP. Why did you give it a 7 and not a 5? What does that do? They usually say something based on kind of change talk, right? They say, well, let's see, if they rated it a 7, they said, well, I am confident because I have a sister that uses CPAP and I could talk to her about it. And, if she's doing it, I could definitely do it. So that's why it's a 7 and not a 5. What would it need to be a 9? Well, I think my sister would maybe she could come over and help me set it up. And that would make it a 9. Then I'd be really confident in using it. Or readiness. What would make that readiness a 9? Well, I would have to do whatever. And then they're kind of planning what they could do to get to that next stage of change. So rulers are nice. They kind of need to be in the context of good rapport when you've established that rapport with people. It's hard to start right off like giving rulers because then they wonder what you're talking about. Assessment, and this is another really fun way to think about your assessment. Think about assessment in sleep medicine. You've got the sleep study interpretation, you've got the download, you've got the Epworth, you've got the insomnia severity index. We have all these neat measures. Why do we usually use them? We usually use them for us to be able to diagnose things and look at things. Motivational interviewing says, how can we share that with patients in order to increase their motivation? And so one thing you're doing is you're really making it personalized. So if your patient is worried about getting dementia, maybe you'd want to share their oxygen saturation and that their oxygen is dipping down, because that's what they're kind of concerned about, or that's one of their concerns and what they're motivated about preventing dementia. It might be if they're worried about driving off the road, you would present the sleep study interpretation, but also include the Epworth and kind of connect that there. So you're looking at your assessment in terms of what information you're going to provide, and you're basing it on the patient and what's going to maybe increase their motivation. And that can be kind of fun. And then it can also lead to, well, how do they get the information? Maybe we want to do a little worksheet where we're showing them, we're taking specific information from the sleep study and giving them that so they can take it home or something like that. Now, it's really helpful. This is a very small thing. It might seem like it's just being polite, but there's a reason for it, that you can actually, before you give them the results, you can say, would you like to hear the results of this study? And what that's doing is it's like you're there working with the patient and you're offering the information as opposed to you telling them, hey, this is the results that I'm going to give you. And that can be really helpful. You can also really look at how they're responding to the results that you're giving them. So it could be that you're watching their nonverbal communication. If you say, so the results of the sleep study show that you have this many apneas, and we actually classify that in the severe range. What are your thoughts about that? Or what do you think about the results of this? And get their impression of it. You can also look at the patient's nonverbal information too, right? If they're like, cringing, or if they're looking really serious, then you can actually address that too, because that's really important information. And you're also really reflecting and elaborating on change talk as well. If they say, oh, this really is high, I didn't realize all this was happening, I was having this many apneas, this is really severe, and then you could kind of elaborate on that. You feel like this is really something that could be detrimental to your health, or something like, some kind of reflection on that. Just a brief example of a way to do assessment that might more capture what the patient concerns are. And that is Mark Aloya. He's done a lot on motivational interviewing with sleep apnea. And he took a group of people who had a sleep study. Half of them, he showed a video of somebody else in the sleep study having apneas. Half the people, he showed the patient seeing themselves during the sleep study. And what he found was that those who viewed themselves or those who viewed themselves struggling, right, having apneas and hypopneas, used CPAP for 2 or more hours per night than those that saw somebody else. So one person who took part in this said, there was a good, he basically said, it made me cry watching it, and to see myself basically drowning in my sleep, it made me very determined to fix that. So actually with that study, I didn't really see any studies after it, so I didn't really see it in a big journal or anything, so I don't know what happened with that, but it's certainly an interesting idea, and it reflects the way of kind of personalizing assessment and the assessment that we give. 2 other techniques that we can use in motivational interviewing. One is what's next, and that would be probably after your discussion with them. So it would be, so what do you make of this now? Or so what are you thinking about sleep apnea now? Or what do you think you'll do? Or what's the first step? You're getting them to kind of think and talk about the direction that they want to go in with this. There's also a summary, and summaries are just basically reflecting back a lot of the change statements that your patient has made. And it can be very short, but it's just kind of letting them hear back in a summary all their reasons for change or the change talk that they've given. It shows that you've been listening, and you can also say, is there anything else, which shows that you're really interested in getting all the information. Right, and make sure that, that we're not missing anything in what they're saying. There are some studies of motivational interviewing in CPAP adherence. I don't think there's anything with oral appliance therapy or Inspire or any of those things. There's a whole bunch of literature, though, in healthcare in general with smoking cessation, addictions, medication adherence, all sorts of different areas. There's lots of, it is evidence-based. The second one there by Aloya is a manual, and so that does give like clinical information like we've been talking about today. And that could be helpful. The other ones, some of them showed that there was better adherence when they had a motivational approach. There was one study that I think showed that if there was more ambivalence, then motivational interviewing was helpful and helped them improve adherence and things like that. So it's about 7 after 4, and I think I will show the video if that's okay. It's about 9 minutes, and it's an example of a person who's coming for an evaluation for her alcohol use. And what I was hoping is that we could look at what principles and techniques of motivational interviewing do you observe in this, and kind of see if we can pick that out. How is the patient responding to this method? And what stage of change do you think this patient is in?
Well, hi, Ms. Clark. My name is Alan Lime. I'm a social worker at the Family Health Center. Dr. Seal asked me if I would spend some time with you today. I'm really glad that you're here. I'm just curious as to why he would send you to me.
Mm-hmm. Well, I came to see Dr. Seal last week because of increasing stress and anxiety that's kind of getting the best of me. And in the course of my appointment with him, he was asking how I was dealing with that stress. And I mentioned that my 1 or 2 glasses of wine a few nights a week is turning into more frequent and maybe 3 or 4 on some nights. Okay. And he had some concerns about that and felt like maybe you could help me with stress or something.
Yeah, so he asked you to see me because you went to him for increased stress, and he's concerned that your alcohol consumption may be a part of that increase. And prior to prescribing you anything, he wanted to make sure that you at least had someone to talk to about that.
I suppose.
Okay. I saw that you filled in one of the pink sheets. May I take a look at that?
Yeah, he told me to fill that out and bring it with me.
Okay, thank you. You say here that you have 4 or more drinks in 1 week. You mentioned that you may be increasing that a little bit as well, and that you have 1 or 2 drinks in one setting.
Typically.
Yeah, and that maybe monthly you have more than that. What kind of drinks do you have? What do you drink when you typically drink?
Wine with my meals. Again, 1 or 2 typically, and more frequently 3 or 4 since my stress has increased.
So it's starting to increase, you're starting to drink a little more. Okay. Well, based on what you put here, it gives you 6 points on this scale. The scale ranges from 0 to 40. So 6 points will put you in what we would consider an at-risk zone. So if it's okay with you, let's just talk a little bit about that.
Okay.
Okay. So the at-risk zone, say it runs 0 to 40. It's not a super high risk, but it certainly could be a risk for maybe increasing stress, maybe some physical ailments related to alcohol as well. Could start to show up if you were to increase your drinking from there or even stay there. This is a typical standard drink size over here. I'm not sure whether that fits your description of a glass of wine or not.
I filled a glass up, so maybe a little more than that.
Yeah, maybe that little space at the top. So perhaps a drink and a half each one. So that would also increase a little bit more. So perhaps maybe drinking more than you indicated on here. And for a woman, healthy woman your age, no more than 3 drinks in one setting is considered to be lower or no risk, and no more than 7 in 1 week.
7 total in 1 week?
7 total in 1 week. And what you say here is that even on this sheet, you're perhaps already drinking more than that. So what do you make of all that?
That's news to me. I thought red wine with your meals is supposed to be healthy, and no more than 7 in a week. That seems kind of prohibitive. Yeah.
It seems a little less than perhaps you've been drinking or what you consider to be healthy drinking. And certainly there's conflicting information out there about what's healthy and what's not healthy. I imagine the increased stress is what concerned Dr. Seal. As your stress increases, and if he were to prescribe you anything, there may be some interaction between the two that would also be a concern for him, I would think. So if you would, what is it that you like about alcohol?
Well, it does, at least in the moment, temporarily reduce my stress. And I, like a good glass of wine. I don't drink the cheap stuff. I like the expensive.
Right. So you like the taste of it, and it does help to lower the stress, even if it's just for that time you're drinking. What are the not so good things about alcohol for you?
Well, the nights that maybe I have couple more glasses than I should, I wake up feeling kind of yuck. And of course, part of my stress is finances, and I mentioned I like the good stuff, and so if I'm drinking more, then I'm increasing my financial burden.
Yeah.
So
your financial stress may be increased by the fact that you're drinking.
yeah, kind of defeating the purpose
Kind of
there.
a catch-22 there, drinking to reduce stress and increasing stress at the same time. So on the one hand it lowers it, and on the other hand it's increasing it, kind of like a seesaw, teeter-totter effect there. What do you make of that, given that on one hand it lowers and the other hand it increases, and now it's increasing even more?
And maybe I need to find some other way to deal with my stress.
Yeah. And I imagine you've had some thoughts of that. What have you thought of trying, if anything?
Well, I've exercised in the past, and that helps. Right now, my schedule is kind of out of whack, and I just really don't know what to do. That's why I came to see Dr. Seal. I thought maybe he could prescribe me something that would help me, when I'm feeling overwhelmed.
And he may be able to. I'm not saying that he cannot. I'm just imagine that he's concerned that if you continue to drink on the level that you are drinking, that whatever he prescribes you, there may be an interaction with the two. I imagine that's his concern. I'm not completely sure. So you've had some success in the past with changing behaviours, and if you were to decide to make any changes here, it sounds like you could draw upon that to make those changes. How important would it be for you on a scale of 0 through 10? I have a little kind of visual here of that. If 0 is not important and 10 is very important, to do something about your drinking right now.
Well, I mean, if it means that it's increasing my stress or he's not going to prescribe me anything because of my drinking, then it's fairly important, maybe about a 7.
That's pretty up there. Why did you choose a 7, not a 5 or a 4?
Well, again, I've got to get things under control. My kids are dependent on me, and I've got to go to work to help ease this financial stress, and so, all those responsibilities.
So there's a lot riding on your decision here on what to do with this. What, if anything, would bring it up to an 8 or 9 on that scale?
Well, the risk that you mentioned about the drug interaction, I certainly can't afford to, have any more stress. So.
Yeah. So you choose to lower your stress rather than increase it, and if lowering your drinking would have that effect, that's something you'd be willing to do right now. How confident are you that you could do something about your drinking?
I'm pretty confident. Probably about a 7 or an 8.
Okay, so it's pretty high up there again. And what if anything would you choose to do? Would it be to cut down? Would it be to quit? I'm just curious about
Well, like I said, I like a good glass of wine. I don't want to quit altogether. I'd be willing to try cutting back. But now, if Dr. Seal would agree to prescribe me something for the anxiety, and it meant that I had to not drink at all, I'd be willing to do that at least for a period of time.
So you'd be willing to stop altogether if that's what was indicated by the physician. Okay. So based on that, how ready are you to do anything right now, whether it's to cut back, whether it's to quit?
Well, again, if I can get something to help me manage, if maybe I can find some other way to deal with the stress, then I'd be pretty ready. Again, maybe about on that scale, maybe an 8.
Okay, so that's pretty high up there as well. It sounds as though you're pretty motivated to do something about this right now, given your responsibilities, given your children relying on you at this point, and just on lowering your anxiety in general. It sounds that that's one of your goals as well. Well, I'm pretty confident that once you decide to do whatever it is you decide to do, you'll be able to follow through with that, based on your experience in the past of making behavior changes. I imagine there's some things there you can draw upon. What's one thing that you could do? I imagine you thought of some things that might help to lower your stress.
Well, the exercise, but again, that's kind of difficult to fit in right now. Hoping that Dr. Seal will prescribe something for me to take when I'm feeling particularly overwhelmed, and maybe just having somebody to talk to bounce some things off of.
One of the things we can offer here is for you to come in and talk to one of our behavioral health specialists. Who may be able to help you talk through this area of your life, this area of increased stress, and sound like responsibility there. And we can make an appointment for you if you like before you leave today to talk to somebody.
That'd be nice.
Great. It also has some information here if you're interested, a pamphlet on alcohol and how what healthy limits are and how it may be affected by medications that you take as well.
Okay.
And I wish you lots of luck. It sounds as though you're really committed to making this shift and this change. And I imagine Dr. Seal will want to follow up with you and see how you do with your change within a few weeks.
Okay.
Again, I look forward to speaking to you in the future.
All right. Thank you very much.
You're very welcome.
Okay, so what did you notice about some of the techniques of motivational interviewing? Is there anything in particular? Yeah. All he did was help direct her, and she really gave all the answers. So he was really facilitating it, wasn't he? Like facilitating her process of change in this and process of understanding. Yeah, good point. Yeah.
I liked how he met her where she was at. He was slowly guided to your point instead of telling her, like through and allowed her to realize.
Yeah, exactly. He really met her where she was at, and then kind of went with her together. And that's kind of the idea, is that you're a partner with the person, kind of going with them through it. Yeah. Did you see any, yeah. What? Yeah, and it did really work. So the idea of using the pros and cons and how that was used, the first question was, what do you like about your drinking? And that got her talking, right? And mentioning things that were important. And then he was also able to say, and what are the downsides of that as well? And she was able to respond to that, right? She was able to really then keep talking about it, which was really good. Yeah. Other things that you noticed? Yeah. What stage of change do you think she was in at the beginning? Right at the beginning there. What's that? Kind of the thinking contemplation stage? Yeah. And I think I'm wondering if she got there more so, right in the beginning. She was kind of saying, I think when she said, oh, that's news to me. I thought drinking alcohol was really healthy, having some glasses of wine. So that made me wonder whether she was starting, and she didn't go in to that appointment thinking, oh, I have an alcohol problem and I really want to address it. She came in because her doctor had recommended, right, because she wanted that medication for stress. So I'm wondering if in the beginning, perhaps she was in pre-contemplation, and that then she said, oh, yeah, I didn't realize I was drinking more than that would put me in that risky area for drinking. But then I think you're right that she really got to that next stage of contemplation. Yeah, because then she was really kind of, I don't know that I sensed a whole lot of ambivalence. Well, there was a little, right? One where she said, well, that's really prohibitive. Boy, that's just having whatever, 3 or whatever, that's prohibitive. But if it's important. So there was a little bit of that in contemplation, that back and forth, that ambivalence as well. Did you notice how they used assessment? So the assessment was normative data, right? It was saying, oh, if you look, this is where you are, in comparison with other people. So it's within what are the norms and where do you fit in there, as opposed to, oh, this is a really high amount or something like that. So, what's that? Yeah, exactly. Where she was seeing, she was able to see that she was drinking a lot more than what a typical drink would be. And so that was also really, I think for her, something that she hadn't even thought of really with that. And so really, so instead of saying, this is, oh, you're drinking too much, right? Then it's a different way of presenting it through the assessment that's being used. Yeah. Any questions about motivational interviewing? Any thoughts before we end? Okay. Well, thank you very much.